Greetings, welcome back to ERMP and Beyond, the pulse of clinical medicine. Join us as we tackle real-world medical cases, enhance our knowledge, and refine our skills with evidence-based practices. Get ready to unravel today's medical mystery with us. So, without any delay, let's dive into the depths of today's medical enigma. A 50-year-old male patient presented with progressive abdominal swelling and easy fatigability of 2 weeks duration. On investigation, liver enzymes are in normal range. Serum albumin is 3.4 grams per deciliter, acidic albumin is 1.8 grams per deciliter, and ascitic protein is 1.9 grams per deciliter. What is the most likely cause of ascites in this patient? A. Heart failure. B. Tuberculosis. C. Cirrhosis. D. Nephrotic syndrome. Welcome back again, everyone. Today, we're going to delve into a fascinating aspect of medical diagnostics, understanding the underlying cause of ascites in patients. Ascites, as many of you know, is the abnormal buildup of fluid in the abdomen, and it can be indicative of various health conditions. To unravel this mystery, we employ a valuable tool called the Serum Ascites Albumin Gradient, or SAAG for short. Let's break down the SAAG calculation. It's a simple subtraction. We take the serum albumin level and subtract the acidic albumin level from it. For our patient, the serum albumin is 3.4 grams per deciliter, and the acidic albumin is 1.8 grams per deciliter. Performing the calculation, we arrive at a SAAG of 1.6 grams per deciliter. Now, what does this number tell us? A SAAG of 1.1 grams per deciliter or higher suggests that the acidic fluid is deficient in albumin, a scenario commonly associated with portal hypertension. This condition is often seen in liver cirrhosis and heart failure. On the other hand, a SAAG lower than 1.1 indicates an abundance of albumin in the acidic fluid, pointing towards causes unrelated to portal hypertension, such as tuberculosis or nephrotic syndrome. For further clarity, we consider the protein level in the acidic fluid. A level of 2.5 grams per deciliter or more could suggest heart-related conditions, while a lower level is indicative of cirrhosis. So, what have we found in our patient? The SAAG is 1.6 grams per deciliter, clearly indicating portal hypertension. Coupled with normal liver enzymes, this reduces the likelihood of acute liver conditions. By analyzing both the serum albumin and acidic protein levels, we can differentiate between the potential causes of ascites. Now, let's consider the most likely cause. Remember the mnemonic the 3C to remember the 3 most common causes of ascites: the cirrhosis, cancers, and the cardiac failure. In the United States, cirrhosis is responsible for about 80% of ascites cases. Other causes include malignancy-related ascites and ascites due to heart failure, which account for 10% and 3% respectively. Less common causes are tuberculosis, dialysis-related issues, and pancreatic diseases. Given our patient's SAAG value of 1.6 grams per deciliter and an acidic fluid protein level of 1.9 grams per deciliter, the most likely cause of ascites is cirrhosis. This aligns with the calculated SAAG value, pointing towards portal hypertension as the culprit. In conclusion, our detective work with SAAG calculation and the clinical context cirrhosis is the most likely diagnosis for the cause of ascites in this patient. It is important to note that while SAAG is a useful tool, the final diagnosis should be made in conjunction with clinical judgment and other supportive investigations. It's been a pleasure sharing insights on today's important topic with you. Your understanding is my top priority, and I trust this session has broadened your knowledge. Don't miss out on future discussions by subscribing. Your feedback is invaluable. Please like, comment, and share your thoughts on how to further enrich your learning experience. Together, let's continue this journey of discovery and improvement. Thank you for engaging with today's content.